Now we're going to just look beyond prostate cancer management, and these are two areas which are very quite sensitive and very important in terms of long-term quality of life of patients. A lot of patients do get bothered by stress incontinence. It's amazing the number of men you see who say, well, look, just treat the cancer, I'll deal with the potency issues. 2 years later, their cancer's gone, they're having a great time and they're depressed because now they can't get erection. So it's an issue that needs to be touched on. As Kay was saying, you do need to approach it before treatment of prostate cancer, and we need to approach it as we follow them up. So it's actually two individual topics, and each individual topic, if I was going to really go into detail, would take an hour each. So I'm going to compress this into 20 minutes, and essentially it's going to be an overview. I'd like to start off with definitions. What is urinary incontinence? Now, the International Continence Society describes it as a complaint of any involuntary leakage of urine. And whether we're talking about male or female, there's three types of incontinence that we generally see. Stress incontinence, where with an increase in abdominal pressure, the bladder pressure gets beyond what we call the urethral closure pressure, and you get leakage of urine. There's urge incontinence. That's that leakage associated with urge, unable to hold on, needing to go and urinate, and what you'll probably be getting towards the end of this session. And mixed incontinence. Now, what we're interested in all of them, but what we commonly see with prostate cancer management or treatment is stress incontinence. We do see urge incontinence, more commonly associated with radiation therapy, but due to time constraints, I'm not going to go through that, but we'll talk about stress mainly. So it's important to have a look at anatomy. That's the drawing that we see in majority of anatomy books, and we all wonder, well, if that's a sphincter and there's a prostate, why removing the prostate or doing radiation therapy, why does it interfere with incontinence? I mean, we should be able to nicely get in that plane. It's a beautiful plane. Our surgeon's incompetent. But in reality, with MRI studies, cadaveric studies, the sphincter is this conical sort of shape. Half the sphincter, or significant portion of the sphincter, actually goes and lies over the apex of the prostate. So if we're going to treat a patient for prostate cancer, if we're going to shoot radiation at this patient or take the prostate out, inevitably we're going to lose a little bit of that sphincter. Now, it doesn't mean every patient is going to be incontinent, because there's a bulk of sphincter here, but there's going to be some degree of dysfunction. Generally, stress incontinence is due to prostate surgery, radical prostatectomy, even TURP less commonly, radical cystoprostatectomy, any pelvic surgery or trauma, and radiation therapy. And what we're interested in particularly is post-prostatectomy stress incontinence. How common is it? Now, as surgeons, we always like to say, well, you know, none of my patients get incontinent. But if we did community studies, sent out letters to patients to find out, are they really incontinent, then it's a significant portion that are incontinent after an operation, 50 to 60%. But that reduces with time. At 3 months, 20 to 30%, 6 months, 5 to 10%, and really at 12 months, we're looking at less than 5% of men would still have a significant issue. If we want to get very specific, do you lose an occasional drop? That number increases dramatically. They're not going to be like they were before an operation, before radiation therapy. There is some change, but in terms of generally being dry, 1 to 5% at 12 months. Now, how can we predict those patients at risk? Those who are older, makes sense, muscles are weaker, sphincter's weaker. Obese patients, again, that probably does make sense. Anatomy is important, the pelvic floor thickness, but how do we measure that? You could do an ultrasound, it's not that accurate. A lot of this is done by research with MRI studies, and it's shown the increased pelvic floor thickness, the better the outcome. Urethral sphincter length, how long is that sphincter? So how much residual sphincter is left after we remove the prostate or treat with radiation therapy? Again, that's done with MRI studies. That's not practical, sending everyone through an MRI before a procedure. And we need to treat the cancer. You're going to refuse to treat someone's cancer because they have a short urethral length. Previous surgery interferes with the outcome. So let's move on to how we improve the outcome of patients. Preoperative factors. I think it's very important before any intervention, prostate cancer intervention, be it radiotherapy or surgery, that early pelvic floor rehabilitation is commenced. And there's good evidence now that a general exercise regime will improve their outcome after surgical intervention. And this is by the Garvan Institute, where they looked at the body composition strength of patients in localized prostate cancer, the effects after surgery, and there's this dramatic decrease in muscle strength, muscle bulk, and therefore starting an exercise regime from the time you decide on treatment, sending them off to an exercise physiologist does improve the outcome. What about intraoperative factors? Preservation of external sphincter, that makes sense. We hope that all of us surgeons actually do that. Nerve sparing. Now, the nerves to the prostate, that's your bladder, that's the prostate, and the nerves that supply erectile function, I'll talk about that a bit later, run directly next to the prostate. Now, they only supply they're only responsible for the erections, but for some reason, we know that if you do a nerve-sparing procedure, the incontinence seems to be better. Is that an indirect effect from being a lot more precise with nerve-sparing, therefore not more precise with preserving the sphincter? Are there nerve fibres that do leave that nerve bundle and go to the sphincter? That hasn't really been proven. And we do little tricks during surgery, some of us do it, some of us don't, that we try to recreate the layers that are holding the sphincter and holding the prostate. Again, controversial whether it helps or not. What about post-operative factors? Early pelvic floor rehabilitation. That does, so majority of patients do start pelvic floor rehab well before surgery. We get them back to it straight after, and it seems to shorten the time to achieve continence. But when you look at studies and they compared the rates of continence at 12 months, whether you've had physiotherapy or done nothing, it's actually similar. I don't believe in myself, and I certainly believe in being proactive and doing physiotherapy, but studies have shown that if you didn't do anything, 12 months, if you were going to be continent, you will be continent. Interestingly, if you take Viagra or Cialis or Levitra, your continence improves. But I wouldn't use that as a treatment. And we don't know what the mechanism is. So pelvic floor rehabilitation, what does that refer to? So obviously we're trying to improve that area of muscle, increase the muscle bulk. And what I tell the patients is there's a few ways to do pelvic floor rehabilitation. You can read in a book and say this is the way to clench your buttock muscles and let's see how you go. Or you get a personal trainer. There's a big difference in the outcome. The other guy who says, well, I want to improve my muscles, but look, I'm really busy. I've got all this paperwork to do. I'll try and get to the gym occasionally. Oh yeah, but I've got to meet my mates down at the bar. Is never going to get there. And that's the same thing that happens with pelvic floor rehabilitation. They have to do it as though they're determined with a physiotherapist on a regular basis and do it as though they're going to the gym. Otherwise, the success rate is very poor. Behavioural therapy is very important. Avoid caffeine drinks. Caffeine, everyone knows that acts as a diuretic, but in actual fact, the caffeine itself attaches to a receptor on the bladder wall known as purinergic receptors. It irritates the bladder and causes earlier contraction of the bladder or earlier sensation to void than without caffeine. So it's not purely a diuretic effect. Decrease alcohol intake makes sense. be aware of the pelvic. They have to change the way they do things. You know, you don't go and carry something heavy, relaxing your pelvic floor muscles. You've got to teach yourself to hold on, clench on as you pick up something. Eventually it'll become second nature. Void before intercourse. There are a lot of men who leak during intercourse, and so making sure their bladder empty helps. But how do we manage these patients whilst they're improving? For that time period while they're improving. We can use pads. There are various types. Penile clamps looks drastic, but it actually works remarkably well. Now these are for patients who have significant urinary incontinence, and I don't actually advise patients to use this unless in a specific situation. They want to go out to dinner, they want to get on a plane. Now if they become reliant on it, using it 24 hours a day, then they're subconsciously relaxing their pelvic floor muscle, you're not actively using it, and their outcome's poorer. So to improve their quality of life, if they have significant incontinence, because some of these men will stay at home, the wife wants to go out to dinner, go to a movie, no, I can't because I'm leaking, I don't like it. Give them this, I think it works very well. Obviously for those who have severe incontinence, you can use condom catheters. Rarely do we need to put a urethral catheter in, but these are severe incontinence. Essentially most people would get away with the pads for a short period of time. But what happens? It's 12 months, things haven't improved. What can we do beyond that? And at that time, we do go back to physiotherapy. There's a good study that shows that even up 55 months, so in 4 years after prostatectomy, with 8 weeks of dedicated pelvic floor rehabilitation with a physiotherapist, there was a 47% satisfaction rate. So it's worthwhile going back and doing that initially to see if we can improve to a reasonable quality of life. But if that all fails, then we're really left with surgical options. There are numerous surgical options, and I'm not going to go through any much in detail, but just to give you an idea, we can put in balloons, we can put in slings of various forms, we can put an artificial urinary sphincter, and I'll go through a couple of these. So this is a silicone balloon. It is inflated with saline, and it's got a little port that sits in the scrotum that we can inject from time to time to increase the bulk of the effect. So that's your bladder, prostate with the cancer, sphincter, urethra. After prostatectomy, the prostate's gone. We put in the balloons on either side of the sphincter. It's purely bulking it up, giving it a bit of compression. And over a period of time, every 6 weeks, we can inject fluid into the balloons till their continence is adequate. It doesn't make them fully continent, but it'll certainly improve it. And it appears like that. A male sling, it's very much similar to what we use in females. It's a polypropylene mesh. And essentially, we make an incision behind the scrotum, a perineal incision, and it sits over the urethra, that's the urethra. And the arms of this goes into the pelvic obturator fossa, so into the groin area. And over a 6-week period, tissue grows into that and holds it tight. And it's essentially elevating this sphincter. What we feel happens after we do a prostate operation is everything kind of sinks down a bit and the sphincter becomes ineffective. It still works, but it's ineffective. So putting the sling in tends to lift everything back up into a position. And it has a reasonably good success rate, about 85%. But again, majority of these devices, and there's another one, the sling, but what the company's gone and done is put a balloon, an inflatable balloon with a little port on it. So we can apply the sling, put it in place. If they're quite not fully dry, we can inject a bit of fluid to give it a bit of bulk. This is relatively new, so I don't have a lot of data on that. But the reality is any of these procedures, we're not aiming to get a patient back to normal. We're not aiming to get them back to what they were before surgical intervention, but trying to improve their quality of life. And if we can get them down to one security pad a day, the occasional leak, that's regarded as successful. It's probably maybe considered by patients as, you know, unfortunate, and I wish I was completely dry, but there's no device that will actually achieve that. The gold standard is this, they're called the artificial urinary sphincter. It's an inflatable circumferential balloon connected to a little pump and a reservoir full of fluid. So what we do is the cuff is put around the urethra, the pump in the scrotum and the balloon in front of the bladder. That continuously stays squeezed. When you want to void, the patient pumps, pushes the fluid out of there into the reservoir. He voids, he's given 90 seconds, and after 90 seconds of pressure in the reservoir, pushes the fluid back into the cuff and it closes off. This has about a 90-95% success rate. And this has been around for 30 years and is probably considered the gold standard, but we use it in patients who have severe incontinence. Obviously, there are risks, mechanical failure, but generally provides a good satisfaction rate. Unfortunately, with any procedure, they're foreign devices, they have complications, infection, erosion, and as I said, mechanical failure. So it's amazing, 10 years ago, there were very few male devices and everyone's concentrating on females, but now there's a new device coming out every few months, and there's yet a new artificial urinary sphincter that's just about to be released with true pressure regulating balloons, a pump that you can actually put in fluid later on, and a more sort of friendly cuff to the urethra. So let's move on to erectile dysfunction. So what's ED? It's the inability to maintain erection sufficient for satisfactory sexual intercourse. It's common, 1 in 10 men. This is just in general, not post-surgery. Over 1 million Australian men are affected. Post-prostate cancer treatment, it's actually hard to give a figure because it can be affected by radiation, both external beam and seed brachytherapy, and the number of patients who are affected by that, it's dependent on what their function was like before. It can be affected by surgery, whether we do what we call a unilateral nerve sparing procedure, spare those nerves, if we spare both nerves, or we do incremental. It's not one nerve on either side, it's a bunch of nerves, and we can spare some and leave some behind. It's affected by pre-existing erectile dysfunction. It's amazing how many people think their erections are normal till you get them to fill out a function form and you realise that it's suboptimal before they even reach treatment. And comorbidities, hypertension, diabetes and medication. So management of these patients, the most important thing is communication, as Kat said before, and they need to realise it can take 24 months to regain function. We commonly use sexual health counsellors, psychologists, because I think it's vitally important that not only do we try to regain their erectile function if they want to, they're able to communicate and their relationship with their partner is also going to survive this process, and encourage them to discuss it. We talk about penile rehabilitation as the management of these patients, but it's quite controversial. Talk about early use of treatments to try and bring back the erections, or waiting till it happens if it's going to happen. And there's no real proof which way to go, but certainly I believe in penile rehabilitation. We commence PDE5 inhibitors before operative intervention, we continue with them afterwards, and we encourage them to stimulate to try and get an erection. They may not get an erection, but like a treatment, they've got to try and stimulate on a regular basis every few days. And if PDE5s don't work, they need to try other therapies. And these are the other therapies that we'll go briefly through: oral medication, vacuum erections, injection, and penile implants. Oral medications, they're expensive, unfortunately, not come on the PBS, and ineffective in 30%. We won't go through how they work. But a lot of media saying how wonderful it is, but despite the hype, it's not really effective. Vacuum devices. can be very useful, but not a very romantic way of dealing with erectile dysfunction. But for patients who don't have success with oral medication, we do use this a lot, and there are various types. You can buy it from a sex health shop or from the internet, and basically it's a vacuum device that causes blood, put the penis in, draws in blood into the penis, and put a ring at the base. The problem is it pulls in venous blood, so it's not oxygenated blood, and as a consequence, we don't generally like it to be used too much. But in addition to other therapies, can be useful, and you can get something that looks like a James Bond suitcase that carries it around. Injection therapy. Most people say, what? What do you want me to do? But it is a highly effective treatment. And it's injecting a substance like prostaglandin, papaverine, into the corpora, causes relaxation of the smooth muscle, blood to flow in it, and erections. There are complications, pain. Eventually you might get some fibrosis and curvature of the penis. And you might get priapism, prolonged erections. But it is probably a good option for majority of these patients. And if it all fails, then we go to the Rolls Royce, and that's a penile implant. And essentially, when you look at overall patient satisfaction, this is really a US slide, so it's a little bit different when you look at the Australian population, but penile implants have a 93% satisfaction rate compared to oral medication or penile injection. I worked a little while in the States at a centre that did penile implants, and men would walk in to discuss management, having not had Viagra and having not had injection therapy or tried a vacuum device, and would go out signing a consent form for a penile implant, which is just not heard of here in Australia. It's a different culture. Ideal for men who have tried other treatments without success, and it's been on the market for 30 years. Obviously, the problems are it requires surgery. There are potential complications, and it's not reversible. You can't put in an implant and the patient can't turn around and say, oh, actually, I don't like it, I'll go back to injections. The penis is not going to work after that. So for us, as surgeons here in Australia, we tend to do it as an end of the line, tried everything else, and we advise having a penile implant. What is it? It's an inflatable, usually made of silicone device, saline within it, a pump in the scrotum, and again a reservoir, very much like the artificial urinary sphincter. The pump goes in the scrotum, and there are patients who have an artificial sphincter and a penile implant. Both the pumps feel different, and their scrotum feels quite bulky, but they cope. The rod goes into the corpora, and there's a balloon that sits in the front of the bladder. And essentially, they pump, feel that, and they get a rigid penis, which is relatively comparable to normal. So, interestingly, if you look at the population who have had it, 92% would recommend it to others. 90% of partners would recommend it to other couples. So, I think it is an option that needs to be considered in these patients. I think there are too many patients who are told once they have Viagra it doesn't work, oh, we can't do anything more. Send them to a sexual health physician or urologist to try injectable therapy, or if you're comfortable prescribing that, try injectable therapy or a vacuum device. If that doesn't work, offer them penile implant surgery. There's no stigma attached to having a penile implant put in, and we can actually get it through a little bit of hard work in the public sector, and health funds do actually fund it. So the health department made the mistake of allowing one patient through for a penile implant, so now they can't say no. Thank you very much.